Welcome to Brain Imaging Essentials, Part 1, Brain Imaging Principles. I am David Lee Gordon, Professor of Neurology. The learning objectives for Brain Imaging Essentials Principles are these. Upon viewing this presentation, learners will be able to list 5 items on CT brain that are white or hyperdense, list 3 items on CT brain that are black or hypodense, list 2 items on CT brain that are gray or isodense, list the 3 main indications for CT brain, describe the benefits of MRI brain over CT brain, relate the indications for the following MRI sequences: T1 weighted without and with contrast, T2 flare, DWI, and SWI/SWAN.
First, let's describe CT and MRI and distinguish them. Both CT, computed tomography, and MRI, magnetic resonance imaging, depict the brain in slices, enabling clinicians to view brain anatomy and pathology. Computed tomography, or CT, does this via X-ray images, whereas magnetic resonance imaging, or MRI, does this by magnet and radio wave images. CT is a density measurement. MRI is a signal intensity measurement. CT is best for axial brain views, whereas MRI may give multiple brain views. There is no claustrophobia limitation in CT because it's a big round open ring that the patient goes through. But most MRI machines do have claustrophobia limitations. In general, at most hospitals and even clinics, CT is quick and accessible, whereas the MRI is slower and less accessible. CT is standing for bone imaging, and MRI is fair for bone imaging. However, CT is fair for soft tissue imaging, and MRI is very good for soft tissue imaging. Likewise, CT does not portray blood flow at all. There's no blood flow detection, whereas MRI is good for blood flow detection. This slide portrays the planes of view available on brain imaging. Both CT and MRI scan allow for axial images. When viewing axial images, imagine the patient is lying on a stretcher supine with his or her legs extended to you. Note that CT and MRI axial images have slightly different orientations, which we will describe on the next slide. MRI, unlike CT, not only portrays axial images, but also portrays coronal and sagittal images. For coronal images, imagine the patient is facing you. And for sagittal images, the patient is facing sideways. So for axial and coronal images, right is on the left and left is on the right. Whereas sagittal images, one side is anterior and the other side is posterior. It is important to realize that the axial views of CT and MRI scans are slightly different. The image on this slide is actually a sagittal MRI used to demonstrate the different orientations for CT and MRI axial images. On the image to the left, slices are shown the way they are obtained on CT brain. And the image on the right, slices are shown the way they are obtained on MRI brain. There is a slight difference in the anterior-posterior orientation of these slices. Note that the posterior aspects of axial slices are lower on CT than on MRI. The result is that when comparing a CT and MRI brain image at about the same level, for example, the posterior aspect of the CT brain may be in the parietal lobe, whereas a similar slice on the MRI brain may still be in the frontal lobe. Volume averaging is an important artifact to understand when interpreting CT and MRI scans of the brain. It is how CT and MRI scans create two-dimensional images. The scanners capture and consolidate a slab of information, usually 3 to 5 millimeters thick, and average the information to create a 2D image. Volume averaging can lead to scan misinterpretation. Anatomic structures may falsely appear to be lesions because the slab captured a portion of the structure at the top or bottom of the slab. When the slab is averaged, the structure appears to be more prominent than expected on the 2D image. Always look at the adjacent slices, for example, slice above and slice below, when evaluating a possible lesion to ensure you are not fooled by volume averaging. Let's look at these pictures to the right. In picture A, slice A, white area appears to be a lesion. But if one looks at just below that, in slice B, just below where slice A was obtained, the lesion in slice A is actually proven to be an extension of normal bone as a result of volume averaging. Now let's review CT brain technique. When performing a CT scan, the patient lies supine on the CT table that is slid through a large open ring, and thus claustrophobia is not usually a problem for patients during CT scans. CT uses X-rays to make cross-sectional axial images, and CT measures density. In essence, CT scans are densitometers, and the density of the items being scanned determine the image color. Hyperdense items are white. In the image to the right, the white arrow points to the white bone, hyperdense bone. Isodense items are gray. In the image to the right, the gray arrow points to the gray parenchyma, the isodense parenchyma. And black items are hypodense. And to the right, the image shows a black arrow pointing to the black air, which is hypodense on the image. The image to the right also portrays the orientation of the CT axial view. Note that the top of the scan is anterior for the patient. The bottom of the scan is posterior aspect of the patient's head. And as we talked about before, the right side of the head is actually on the left side of the image, and the left side of the head is on the right side of the image. The indications for CT brain include acute blood, as opposed to subacute or chronic blood, which are not as easily seen on a CT brain. Mass effect, a very important concept to understand when viewing brain images. Mass effect is compression of adjacent structures with possible midline shift and increased intracranial pressure. That can occur as a result of tumors, abscesses, hemorrhages, etc. CT scan is also good for viewing bone fractures. So if you think about it, in general, CT brain is excellent in emergency situations where you're looking for acute blood, mass effect, and bone fractures. The limitations of CT brain are that it has fair sensitivity for parenchymal disease in general and may be obscured by bony artifact. Bony artifact especially interferes with imaging of the inferior temporal lobes in the middle cranial fossa and the brainstem in the posterior fossa. This is because the middle cranial fossa and posterior fossa, in essence, form a cup of bone with parenchyma in the middle. And when the X-rays go through bone and then parenchyma and then bone, it creates a streaky artifact in the parenchyma. CT brains can be performed without or with iodine-based intravenous or IV contrast. And this IV contrast may trigger allergic reactions and is also nephrotoxic. So contrast scans are best obtained when patients have normal renal function. This slide shows examples of things that are white or hyperdense on a CT brain. The ocular lens, bone, contrast dye, calcifications, acute blood, and metal, such as bullets, in this case with streak artifact, or aneurysm coils in other pictures, are white or hyperdense on CT scans. This slide shows things that are black or hypodense on CT scans. Fat, such as the retroorbital fat, air, such as in the sinuses or mastoid air cells, and cerebrospinal fluid, which in essence is water density, are all black or hypodense on a CT scan. This slide shows things that are gray or isodense on a CT. On the CT, parenchyma is gray, but there are different shades of gray. White matter is actually darker than gray matter. So first of all, soft tissue parenchyma is gray or isodense on a CT. And less dense tissue is dark gray. More dense tissue is light gray. In the brain, white matter is dark gray because it primarily consists of less dense or a fluffy myelin. Whereas gray matter is a lighter gray because it's more dense. The cortex, basal ganglia, and thalami consist of densely packed neurons. So in the picture to the right, one can see that the cortex, the cerebral cortex, the basal ganglia are both a lighter gray. And yet the white matter, for example, in the posterior limb of the internal capsule, where this arrow is pointing, is darker, even though it's so-called white matter. Let's now talk about MRI brain technique and image colors. In an MRI, the patient lies on an MRI table, is slid into a small, narrow, dark space, and hears loud, repetitive banging noise. So it is more of a problem for patients with claustrophobia or wide shoulders who can't fit into the MRI space. MRI uses a magnet and radiofrequency pulses to create cross-sectional pictures in multiple planes. And image colors are based on signal intensity, not density like on a CT, signal intensity. Hyper-intense tissue has increased signal and is white. Hypo-intense tissue is decreased signal, is black. And iso-intense tissue is gray on an MRI scan. MRI brain is technically difficult to obtain in some patients, such as those who are very young, obese or broad-shouldered, or are very ill, agitated, or claustrophobic. Some outpatient facilities have what are called open magnets that eliminate the claustrophobia problem, but the imaging quality usually suffers in these magnets. Some patients require sedation, such as the young children and anxious or agitated patients. One cannot perform MRI in patients with ferromagnetic metal that can be moved and damage adjacent tissue in patients, such as metal fragments in the eyes of welders. Welders often don't realize that there are micro metal fragments they have in their eyes, and the MRI can make those move and damage the eye. Bullets and soft tissue is another example. Most pacemakers and cardiac defibrillators cannot be put through the MRI brain. There are some that are MRI compatible. Most are not. MRI brain has distinct advantages over CT brain. For example, MRI brains are multiplanar, able to change views easily without moving the patient, including axial, sagittal, and coronal images. MRI brain is superior for posterior and middle fossa imaging, with resultant superior visualization of the brainstem and inferior temporal lobes. MRI brain is excellent for acute ischemia detection. Certain sequences detect ischemic changes within minutes. MRI brain is superior for soft tissue sensitivity, more sensitive for parenchymal lesions, especially infarctions. MRI brain is better for blood detection. Unlike CT, MRI detects chronic blood, and certain sequences detect acute blood as well as CT. And MRI brain is better for blood flow detection. blood flow detection. It gives information about flow in vessels that CT scan does not give.
There are many different MRI brain sequences, and just like with CT, one can obtain an MRI without or with IV contrast. The contrast used in MRI is called gadolinium. It is not iodine-based, but like the iodine-based contrast material, it can be nephrotoxic. When ordering an MRI, the patient will have multiple different image sequences, and accurate interpretation of the MRI depends on knowledge and comparison of the different image sequences. The most commonly used sequences are T1 weighted image, T2 weighted image, T2 flare, DWI, also known as diffusion weighted imaging, ADC, or apparent diffusion coefficient, and SWI, or SWAN images.
A consideration when interpreting an MRI brain is flow artifact. Flow artifact may occur when two arteries or two venous sinuses are visualized in the same image, with resultant obscuring of the visualization of the parenchyma. In the image to the right, two white arrows point to the carotid arteries in the cavernous sinus. Those two arteries in this image have resulted in an obscuration of the temporal lobes bilaterally due to flow artifact, depicted by the arrows with stripes. On MRI brain T1 weighted images, cerebrospinal fluid, CSF, is black, and most lesions are dark, including edema, water, acute infarctions, and gliosis. T1 weighted images are poor for seeing lesions without IV contrast or gadolinium. They're best used for suspected mass lesions or acute demyelination, comparing the pre-contrast to the post-contrast T1 weighted images. Calcium and bone are black on T1 weighted images, and blood varies in color with age. In general, we only use contrast in T1 weighted MRI scans. On MRI brain T2 weighted images, CSF is white, and most lesions are white, including edema, water, acute infarction, and gliosis. T2 weighted images are very good for seeing lesions, but sometimes it is difficult to distinguish a lesion and cerebrospinal fluid. Also, T2 weighted images cannot see very new infarctions and cannot distinguish new and old lesions. On T2 weighted images, calcium and bone are black, and blood varies in color with age. Note in the image to the right, there are several lesions that are white on the T2 weighted image for patient X. It is not possible to determine which of the lesions are new and which are old.
MRI brain T2 flare images are very useful. FLARE is an acronym standing for Fluid Attenuated Inversion Recovery. T2 flare are in essence T2 weighted images with standing water turned black. So CSF becomes black, old lacunar infarctions become black, and encephalomalacia turn black. But like T2 weighted images, most lesions are white, such as edema, water, acute infarction, gliosis. T2 flare images are best for seeing chronic lesions and subacute blood, but cannot see very new infarctions, cannot distinguish new and old lesions, and lesions may be inadvertently erased, so one must always compare T2 flare images to T2 weighted images. On T2 flare, calcium and bone are black, and blood color varies with age. In this T2 flare image on this slide, one can see very clearly the multiple areas of gliosis from the old infarctions. And unlike on the previous slide from the same patient, patient X, where you saw a T2 weighted images, the CSF is black, so it's easier to distinguish lesion from CSF. But like T2 flare cannot distinguish new and old lesions. DWI stands for diffusion weighted imaging. On DWI, the CSF is black, just like on T2 FLAIR images. However, DWI shows new infarctions, unlike T2 FLAIR. DWI visualizes infarctions a few minutes to a few weeks old. Older infarctions are not seen, and non-ischemic lesions are not seen. Now, the images may appear fuzzy, but still, the DWI is exceedingly useful in figuring out if a patient has a new infarction. Now, to make sure, compare DWI to T2 FLAIR to distinguish what's new and what's old, and compare DWI to ADC, apparent diffusion coefficient, to ensure the infarction is real. Since DWI may have false positives, it can show lesions due to other conditions, such as a seizure or a T2 shine-through phenomenon. In the image on this slide, this is from the same patient, patient X, at the same time as the T2 weighted image and T2 FLAIR image seen on the previous two slides. Note on this image, DWI, you see a new infarction, not appreciated on T2 weighted or T2 FLAIR, and yet you do not see the old infarctions, which were seen on the T2 weighted and FLAIR images.
ADC, standing for apparent diffusion coefficient, is another type of MRI brain image. On MRI brain ADC, CSF is white, and ADC is best for confirming DWI lesions are truly infarctions. New infarctions are black on an ADC. The problem is that hemorrhage may also be black, so you must compare the ADC to other MR images. And like the DWI, the images are a bit fuzzy. This is an ADC image from another patient, not patient X, showing a temporal infarction being black on the ADC.
SWI or SWAN images are susceptibility-weighted MRI sequences generated from T2 star GRE or gradient recall echo sequences. SWI or SWAN images detect iron and calcium better than other sequences. They detect blood better than other sequences, both acute and chronic. The parenchyma and non-blood lesions appear fuzzy. Look at these SWAN images on this slide. Subacute blood is of mixed intensity, white and black on SWAN, and chronic blood and calcium are purely black or hypointense on SWAN. The different terms, SWI, susceptibility weighted imaging, and SWAN, susceptibility weighted angiography, are equivalent sequences used by different MRI companies. Different types of lesions have different colors or signal intensities on MRI brain spin echo or SE images. On this slide, we're differentiating vasogenic edema, fluid seeping through the blood-brain barrier, versus cytotoxic edema, in which there's swelling of cells, typically due to ischemia. Note that on T1 weighted images, both vasogenic edema and cytotoxic edema are dark gray, an isointense to hypointense, in between isointense and hypointense. On T2 weighted images and T2 FLAIR images, both vasogenic edema and cytotoxic edema are white or hyperintense. Now, a big difference is that the vasogenic edema only occurs in the white matter, whereas cytotoxic edema involves both white and gray matter. And the best way to distinguish vasogenic and cytotoxic edema is the DWI, diffusion weighted imaging, in which vasogenic edema is isointense, but cytotoxic edema is hyperintense, white, for at least the first up to 14 to 28 days after the infarction. After viewing this presentation, you should be able to accomplish the stated learning objectives reproduced on this slide for your review. This is the end of this presentation, a production of DLG Insight, innovative neuroscience ideas and thoughts on education.